Hello, I would like to discuss the discharge plans for Miss Devine. As we both know, Miss Devine was admitted today to rule out her preterm labor. Her past medical history of preterm births place her at higher risk. According to Robinson et al. In 2022, she is at a 33% risk for her third pregnancy to be preterm, and she's had two previous preterm births between the gestational ages of 32 and 34 weeks. Her admission assessment has ruled out a differential diagnosis of medical or surgical condition, as well as abrupto placentae, chorioamniotitis, and any rupture of her membranes. And as you note, despite her contractions, her cervix is long and closed. So according to Lockwood, in 2022, a cervical length greater than 30 millimeters is at lowered risk for delivering preterm. So my concern is placing this patient on strict bed rest, and I would recommend against strict bed rest for Miss Devine. Lockwood and Bars in 2022 note that there is beneficial qualities to bed rest because it does increase blood flow to the fetus, which can help lessen the chance for a lowered birth weight. But there's been no beneficial supportive evidence that suggests strict bed rest reduces the risks for preterm labor. In addition, the American College of Obstetrics and Gynecology in 2020 agrees with Lockwood and Bars, and they also suggest against bed rest. And they even note that bed rest, there's been some evidence to date to support that bed rest does more harm than good by placing the mother at higher risk for blood coagulation. And then results from a 2018 study by Lavina et al. They performed a secondary analysis on the preterm prediction study of Eunice Kennedy Shriver National Institute of Child Health and Human Development and Maternal Fetal Medicine. They also agree that placing a patient who is at high risk for preterm birth places a woman at even higher risk for preterm birth in their study. So, I really think the evidence is there to support that she should not be on strict bed rest. So what I was thinking is that since stress is related to preterm labor, I also would recommend that we incorporate some motivational interviewing to identify if she has any stressors and help her cope with those stressors. According to Rolnick et al., implementing motivational interviewing skills will allow the patient to learn about themselves and then grow through the changes of their lives in a positive manner. So in addition, Cohen Jibhari in 2022 note that preterm births from stress is higher in non-Hispanic, Black, and Indigenous women than for white, Asian, or Hispanic women. And stressors are typically related to both biological and environmental factors. That includes social and economic disadvantages, lower educational attainment, residence in a disadvantaged area, and structural racism, as well as lack of access to prenatal care. So I do think that it's pretty important that we rule that out. And Cohen Jabhari in 22 suggests that it is extremely important because the fetal brain is especially vulnerable from the rapid neurodevelopment occurring in utero. Stress that occurs in the pregnant female is transmitted through the biological and behavior factors to the developing fetus, and it influences the fetal tissue and biological systems, and ultimately contributing to adverse health outcomes. So also prior to our discharge today, I would like to add a few tests and screenings. I would like to add a screening for substance abuse utilizing the NIDA quick screen, because according to Jordan et al. In 2019, modifiable risk factors for preterm birth are smoking and substance abuse. So it is important to identify if she's at risk and implement smoking cessation and treatment for substance abuse disorder. And I would also like to culture her urine. Lockwood and Bars suggest that pregnant women who can be asymptomatic and have pyelonephritis or urinary tract infections, and that also can contribute to preterm labor. And then finally, I do want to make sure that the health of the fetus is reassuring and include a non-stress test as recommended by Lockwood and Bars 2022. So Miller and Chakrabarty in 2022 explained that stress test will allow an assessment of the fetal heart rate patterns, and it's useful to identify if the risk of the fetus is at harm and to confirm that there's no hypoxia that could threaten the continuation of the pregnancy. So lastly, I would recommend starting Miss Divine on hydroprogesterone caporate, 250 milligrams intramuscularly prior to her discharge, and set up weekly appointments for administration until 37 weeks or until she delivers. Norwitz and Bars note that adding this progesterone supplement might help reduce her chances for preterm labor by up to 20%. And furthermore, Shadewald et al. Note that the American College of Gynecologists guidelines are to administer this drug as a supplement to all pregnant women of singleton pregnancies with a history of preterm birth from 16 weeks to 37 weeks on a weekly basis. And thanks for letting me share that with you, Doctor. Have a great day.